injections described as regenerative medicine have become one of the most heavily marketed options for people with knee arthritis. If you search online or attend a seminar, you may hear language about rebuilding cartilage, restoring joints, or reversing arthritis. Are you ready to get back to what you love after knee replacement? The Total Knee Success Podcast is your trusted guide with practical tips, evidence-based strategies, and no fluff. It's not personal medical advice, just solid education to help you manage pain, regain mobility, and get back to living the life you love. Let's dive in. Welcome back to the Total Knee Success Podcast. I'm Michelle. This episode is the fourth and final conversation in our four-part series on injections people consider before total knee replacement. In the first three episodes, we looked at some of the most common injection options people hear about for knee arthritis: cortisone injections, hyaluronic acid or gel injections, and platelet-rich plasma, often called PRP. If you haven't listened to those episodes yet, I recommend going back and listening to them after you finish this episode, so the full picture of these treatments makes sense together. By the end of this episode, you'll understand what most stem cell knee injections actually contain, what the science currently shows about their effects on arthritis, and how to evaluate these treatments with clarity instead of marketing pressure. Over the last several years, injections described as regenerative medicine have become one of the most heavily marketed options for people with knee arthritis. If you search online or attend a seminar, you may hear language about rebuilding cartilage, restoring joints, or reversing arthritis. For someone living with knee pain, these promises are powerful. When walking becomes difficult, when stairs feel like a challenge, and when sleep is interrupted by aching joints, the idea that a single injection could repair the knee can feel incredibly hopeful. But hope works best when it's paired with clear understanding, and that's the goal of today's conversation. That's also why this injection series is important. In the last episode, we talked about platelet-rich plasma, often called PRP. That treatment uses concentrated components from your own blood. Stem cell injections are often discussed in the same breath as PRP, but they're not the same therapy, and the scientific questions around them are different. So today we'll take a careful look at what stem cell injections actually are, what most clinics are truly injecting, how these treatments are regulated, and what current research suggests about their effects on knee arthritis. And along the way, we'll also talk about something that's easy to overlook: how marketing language can sometimes move faster than evidence. Let's start with the phrase itself: stem cells. Stem cells are a real and fascinating part of biology. In simple terms, stem cells are cells that have the potential to develop into other types of cells in the body. In laboratory settings, scientists study them because of their ability to differentiate into bone, cartilage, muscle, and other tissues. Because cartilage damage is a central feature of knee osteoarthritis, the idea that stem cells could regenerate cartilage has captured a lot of attention. And in laboratory experiments, researchers have indeed observed stem cells forming cartilage-like tissue under certain conditions. But laboratory science and clinical treatment are two very different environments. Inside a controlled research setting, scientists can isolate specific cell populations, control growth factors, adjust culture conditions, and guide cells through a very precise process. Inside a human knee joint with advanced arthritis, the environment is very different. There's inflammation, there are mechanical stresses from walking, standing, and climbing stairs, and there are structural changes that may have developed over many years. That difference between laboratory potential and real-world clinical outcomes is an important piece of this conversation. Now let's talk about what most stem cell injections for the knee actually contain. When people hear the term stem cell therapy, many imagine a highly purified population of regenerative cells being injected into the joint. In reality, most treatments offered in outpatient clinics are not purified stem cell preparations. Instead, they're typically derived from one of two sources: bone marrow or adipose tissue, which is fat tissue. In a bone marrow procedure, a small amount of marrow is aspirated, usually from the pelvis. That sample is processed and then injected into the knee. In an adipose-derived procedure, fat tissues may be harvested and processed before being injected. Both of these preparations contain a mixture of cells and biological components. Within that mixture, there may be a very small percentage of cells that have stem-like characteristics. but they are not large populations of highly purified stem cells like those used in laboratory studies. And that distinction is important when evaluating claims about cartilage regeneration. You may also hear ethical discussions connected to the phrase stem cells, and that's important to address. Many people associate the term stem cells with embryonic stem cell research, which has been debated for ethical and religious reasons. Embryonic stem cells come from very early stage embryos and have been used primarily in laboratory research and highly regulated medical trials. The injections marketed for knee arthritis today are different. In orthopedic clinics, the procedures described as stem cell treatments typically use cells taken from the patient's own body, most often bone marrow or adipose or fat tissue. Because these are autologous cells, meaning they come from the same patient receiving the treatment, the ethical questions surrounding embryonic stem cell research are not part of these particular procedures. It's also helpful to know that there are currently no FDA-approved orthopedic treatments that use embryonic stem cells. So while the ethical debate around embryonic stem cells is an important conversation in medicine, it is separate from the biologic injections most people are offered for knee arthritis. With that distinction in mind, it becomes easier to look at what these treatments are designed to do and what the research currently shows. However, a different type of controversy sometimes arises: how these treatments are marketed and how their benefits are explained to patients. Many medical organizations have encouraged careful communication so that patients understand the difference between promising laboratory science and treatments that have already demonstrated consistent clinical results. In the United States, the Food and Drug Administration regulates biological therapies. Highly manipulated cell products or expanded stem cell treatments generally require extensive clinical trials before approval. Many injections marketed as stem cell therapy use cells taken from a patient's own body that are processed and then injected during the same procedure. Because the cells come from the same patient and are only minimally processed, clinics are sometimes able to offer these treatments without the large clinical trials that medications have to go through. That regulatory pathway means these treatments may be available to patients even though they have not yet gone through the same level of clinical testing required for many pharmaceutical therapies. This does not automatically mean the treatments are ineffective, but it does mean the evidence base is still developing. So what does current research actually show? Studies investigating bone marrow-derived or adipose-derived injections for knee osteoarthritis have reported mixed results. For example, clinical trials using bone marrow-derived mesenchymal stem cells have shown modest improvements in pain and function for some patients, but structural changes in joint cartilage have been inconsistent across studies. Some small clinical trials using adipose-derived mesenchymal stem cells have also reported symptom improvement in small areas of cartilage signal change on MRI. But these studies typically involve small patient groups, and the findings have not been consistently reproduced across larger trials. In laboratory research and early clinical trials, scientists have also studied expanded mesenchymal cells that are grown and multiplied in controlled laboratory environments before being injected into joints. These approaches are scientifically promising, but require extensive regulatory oversight and are not currently routine treatments for knee arthritis. What remains uncertain is whether these treatments reliably change the structure of the joint itself. In other words, do they rebuild cartilage in a clinically meaningful way? At this point, the strongest evidence supporting true cartilage regeneration in humans with advanced knee arthritis remains limited. Some small studies have reported cartilage signal or thickness changes on MRI after stem cell type injections, but consistent structural restoration of joint cartilage has not been demonstrated across larger trials. Even when MRI shows areas where cartilage appears thicker or improved, researchers still look closely at what type of cartilage is forming. When cartilage changes are reported, researchers still examine whether the tissue resembles normal hyaline cartilage or fibrocartilage, which is more similar to scar tissue and may not provide the same long-term durability inside the joint. That does not eliminate the possibility that certain biologic therapies could evolve in the future. The field of regenerative medicine is active and expanding. But right now, the gap between what is scientifically promising and what is clinically proven is still significant, and this is early 2026. Another factor that deserves attention is variability. One clinic may process bone marrow differently than another, and one preparation may contain different concentrations of cells or growth factors compared with another. That variability makes it difficult to compare results across studies or guarantee consistent outcomes for patients. In contrast, treatments that have undergone large clinical trials tend to have standardized protocols that allow clearer evaluation of effectiveness. This is one reason why interpreting research on biologic injections can be challenging. The therapy described in one study may not be identical to the therapy offered in another clinic. Now let's talk about expectations. When patients hear the phrase regenerative medicine, it can create the expectation that arthritis itself might be reversed. But osteoarthritis is not simply a small cartilage defect that can be patched or replaced. It's a complex condition involving cartilage loss, changes in bone beneath the joint surface, inflammation of surrounding tissues, and changes in how the joint moves and carries load. When arthritis reaches an advanced stage, those structural changes extend beyond cartilage alone. That complexity helps explain why a single injection is unlikely to restore an arthritic joint to its original structure at this point. This is why total knee replacement remains the most predictable and well-studied treatment for advanced arthritis when pain and function decline significantly. Surgical joint replacement does not regenerate cartilage. Instead, it replaces the damaged joint surfaces with prosthetic components designed to restore alignment, movement, and load distribution. For many patients, that structural correction provides a level of pain relief and functional improvement that injections cannot achieve. That does not mean that biologic injections have no role. Some patients do experience symptom relief from certain injection therapies, although responses can vary widely. In certain stages of arthritis, temporary improvements in pain can help people stay active or delay surgery. Talk to your orthopedist about this. The key is understanding what a treatment is designed to do. Is the goal symptom relief, improved activity tolerance, or structural joint regeneration? When those goals are clarified, decisions become easier. Before we continue, I want to mention something that may help if knee replacement is on your horizon. I created a free guide called the Total Knee Success 14-Day Launch Plan. It gives you a clear checklist for the final 2 weeks before surgery, so you know exactly what to prepare, what to expect, and how to set yourself up for a smoother first week after surgery. It's educational in nature. If you'd like a copy, you can download it through the link in the show notes. And let's come back to a central question. Are stem cell injections worth considering before knee replacement? The honest answer is that the decision depends on your goals, the stage of your arthritis, and your tolerance for uncertainty. If someone hopes to regenerate cartilage and reverse advanced arthritis, current evidence does not strongly support that expectation. If someone understands that the goal is potential symptom improvement rather than structural repair, the conversation becomes different. Cost is another consideration. Most stem cell injections for knee arthritis are not currently covered by insurance and are typically paid for out of pocket. Treatments commonly range from several $1,000s to well over $5,000 per injection, depending on the clinic and the type of preparation used. Some clinics also recommend more than one injection. When evaluating any treatment with that level of financial investment, asking clear questions becomes especially important. What outcomes have been demonstrated in peer-reviewed studies? What percentage of patients experience meaningful improvement? How long do those improvements typically last? And what alternatives exist that may offer similar benefits with stronger evidence? These are reasonable questions. They're also the questions that help patients make confident decisions. Before we finish today, I want to return to a broader idea. Innovation in medicine is important. Many treatments that are standard today began as experimental ideas, but innovation and evidence need time to meet each other. Sometimes new treatments become widely available before long-term research has had time to fully evaluate them. The goal of conversations like this one is not to dismiss emerging therapies. It's to place them within the context of what we currently know. When you understand what a treatment can realistically achieve, expectations begin to match reality. And that makes it much easier to decide what direction is right for you. Next week, we begin a new series called Knee Replacement Myths that cost people time and money. In the first episode of the series, we'll look at one of the most common phrases people tell me they hear in their orthopedic office, and that's bone-on-bone arthritis. Many patients are told that once imaging shows bone touching bone, surgery is the only option. The relationship between imaging and symptoms is far more complex than that phrase suggests. So in the next episode, we'll explore what bone-on-bone actually means and how imaging relates to pain, so you have the information you need to decide what timing feels right for you. Thanks for joining me. I'm Michelle, and this has been the Total Knee Success Podcast. This podcast is for educational purposes only. Discover more at totalkneesuccess.com, and be sure to subscribe and share, because every step forward takes you closer to living the life you love.